Hi, I'm Nicole Neal, and today I'm going to be talking about pulmonary thromboembolisms. A pulmonary embolism occurs when a thrombus travels from the venous circulation, DVTs, to the pulmonary vasculature and then gets lodged in the pulmonary arterial system. The incidence rate of PEs are unknown, but it is estimated that in the United States, about a third of all hospitalized patients are at risk of developing a venous thromboembolism. Pulmonary embolisms, also called PEs, are responsible for between 100,000 to 200,000 deaths per year in the U.S. It is the third most common cause of cardiovascular death after myocardial infarction and CVAs. The majority of PEs originate as venous thromboembolisms in the legs or pelvic veins. A PA occurs when a deep venous thrombi detaches and embolizes to the pulmonary circulation. Pulmonary vascular occlusion occurs and impairs oxygen exchange and circulation. The lower lobes of the lungs are more frequently affected than the upper, with bilateral involvement being common. For larger emboli, they most commonly wedge in the main pulmonary artery, while smaller emboli occlude the peripheral arteries. A peripheral PE can lead to a pulmonary infarction, which will manifest by intraalveolar hemorrhage. That obstruction of the pulmonary arteries creates a dead space of ventilation as alveolar ventilation exceeds the pulmonary capillary blood flow, which contributes to the ventilation perfusion issue. Additionally, humoral mediators like serotonin and thromboxane are released from activated platelets and may trigger vasoconstriction in unaffected areas of the lungs. As the pulmonary artery pressure increases, the right ventricular afterload of the heart increases, leading to right ventricular failure. As the right ventricular failure progresses, impairment in the left ventricular may develop. Ultimately, rapid progression of the described symptoms leads to myocardial ischemia, which causes death. The need for prompt, immediate recognition of PEs is crucial to decrease mortality. Early treatment is associated with higher survival rate, while the failure to diagnose PEs is extremely dangerous, with 30% of all patients dying. That being said, it is unfortunate that many PEs can be asymptomatic. The characteristic signs and symptoms of a patient that is symptomatic includes tachycardia, dyspnea, chest pain, hypoxemia, and shock. Additionally, a patient may present with other conditions like acute MI, congestive heart failure, and pneumonia. The treatment for patients with a PE that are hemodynamically stable is parenteral anticoagulation with subsequent conversion to vitamin K antagonists. Due to the fact that early initiation of treatment is essential to improve patient outcomes, it is necessary for the advanced practice nurse to be inquiring about symptomology of DVTs, which could lead to PEs, and PEs themselves. Additionally, because PEs are so dangerous and have such a high likelihood of occurrence, it is necessary for the nurse to be assessing, communicating, and paying close attention for patients at risk of PEs in order to proactively diagnose if one does develop. The advanced practice nurse providing supportive care, like relaxation therapy and oxygen therapy, can be supportive as well. Like all illnesses or disease processes, the role of the Christian nurse in this situation is to provide Christian-focused care, enforced by the qualities of compassion and empathy, while continuing to pray for the nurse's patients independently. And that concludes my presentation. I hope that you guys enjoyed listening to this, and I look forward to watching your presentations. Have a great week.